My name is Dr. James Waldron. I am a GP working in Bulwell in Nottingham. I also wear many other hats, largely education and engagement. And I love, I love reaching out and educating people on a variety of different topics. And I'm here in my capacity today as a GP associate for the Nottinghamshire Alliance Training Hub. And we aim to put across lots and lots of events and education and updates and training to help you guys, progress your careers, be more confident, learn new skills, and hopefully that's what you're expecting for today. This is kind of aimed at this sort of the intermediate level, so people that are going to be seeing patients independently, but perhaps need some additional confidence or understanding about why we do some of the things that we do. And so hopefully that sounds good. Hopefully that's what you're expecting. This is going to be a very interactive talk, so you're going to have lots and lots of time to pop your ideas or thoughts in the chat. So what to expect from today? Well, it's going to be an introduction to the topics. So this is for sort of an intermediate level of people looking to build their confidence and their skills in this area. It is going to be highly interactive. So there's going to be lots of times where I'm going to call on you to put stuff in the chat to answer questions and to put your thoughts in. The quicker we do that, the quicker we move through the content, because there's a lot. We started out when I was writing this, I was trying to do a case study for each bit. I got to 12 and then ended up stopping. So perhaps if you feel like there is going to be some benefit, please ask us, and we're happy to do some more. We can do some of this in a bit more detail, but this is an overview, and there's going to be an opportunity to ask questions, and I in fact would encourage you to ask as many questions as you can through this, of anything that I can help you with as a real life jobbing GP, but also as an educator in this context. So what's the aim for today? So we're going to explore the consultation with patients that present with tired all the time, which is going to be, from this point, going to be abbreviated to TAT. Okay, we're going to outline the approach to TAT consultation, outline common investigations that may be required, describe clinical reasoning, and describe a few important red flags as we go through that may indicate serious underlying conditions. I would recommend you take lots of notes as we go through, because there's going to be, so some of the slides are going to be more inclusive than others, but I'm happy to share a PDF of this afterwards. But I just ask if you would mind not sharing it with anybody that's outside of this meeting, but please encourage them to come on to the next time we do this. We're going to do this lots of times during the year. So first of all, the question, why is tired all the time such a challenge? I'll ask you, why is a patient that says, hey, I'm feeling tired all the time, I'm just exhausted. What is the challenge here? Why is it such a challenge for us? Primary care. What's the cause? Yeah, well, exactly, because why is that question? Somebody says I come in, I've got chest pain, you've got something to aim at. Patient expectations, yep, they want a blood test, they want some investigations. Yeah. What is the objective measure for tiredness or fatigue levels? What does that mean to patient A is to mean the same things to patient B? What else? It is super vague. Yeah, it is 5 to 10% of all GP consults are, I'm feeling tired. What's going on? And it can almost mean anything. Lots of causes. Yeah, struggle to investigate all within the appointment time. And in fact, we more or less can't. It's a losing battle. Yet differential diagnosis, associated comorbidities. And you can get to the situation where your tests are so complex and your differentials are so all over the place that it's very, very challenging to actually know what to do. And multiple causes in different systems. Yeah, and you might end up with lots of things in the same part. Yep, absolutely. Identify loads of stuff there, and the patient expectations are really high. And then importantly, you can investigate people up to the eyeballs, but around about 1 in 3 times, you don't ever find a cause. But the good news is that most of them get better without further investigation. So around about 50% of people you never see again that initially present. Yeah, absolutely. It might be a problem. Yeah, it might be a problem of metabolic disease, and we might be aiming at things that patients, well, they want an answer that's a medical problem, rather than actually maybe need to be moving more, losing some weight, and similar sort of interventions are around this. So what's the big challenge? In a nutshell, it's balancing reassurance with vigilance. What do we want to reassure the patient of? What do we want to reassure ourselves of? But also making sure that we're not going to miss something serious. Within capacity, support available, and colleagues mentioned here about time available. Within our medical knowledge, and of course as generalists, this can be really challenging, and especially we'll all have our own little niches of this, and we want to do a sort of a complete job as we can, but we might need to actually say, really, this is sort of beyond my remit, and we do that as general practitioners as well. And then importantly, without doing every test under the sun. Next bit question for you. What do I actually mean by tired? What is tired? How might we start to explore this? I'm feeling really tired. Sleep, brilliant. Mood, physical symptoms. Depression can certainly be, yeah. So, I mean, yeah, so it's interesting. Depression and hyperthyroidism are things that might cause tiredness, but are a bit difficult to define. Like, what is the, what is the tiredness that comes from depression versus the tiredness that comes with hyperthyroidism? Function, love that, Kelly. Yeah. So what is their functional level like this? Refreshed after a night's sleep. And we're going to come on to a little bit about sleep as well. Managing ADL, so impact on life, cannot initiate the activities they do mentally or physically. I really like that. Yeah, initiate, but also maintain those activities. But this is exactly what I mean. So this is why I put it on a page. It's actually difficult to say, like, what does actually tired all the time mean? Is it sleepiness or is it fatigue? Well, I mean, to start with this, I mean, there's no universal definition of sleepiness or fatigue. Sleepiness, perhaps, and I got this from Very Well Health, which actually I found quite a useful website when trying to explore this topic. Sleepiness is the desire to fall asleep. It builds as you're awake. It's impairment of falling asleep, quality or quantity. And actually, this is probably quite a good definition, because sometimes when patients come in and say, oh, I'm just tired all the time, it is a sleep issue. It is a sleep problem. Whereas fatigue, we might explore as severe mental and physical exhaustion, not somnolence or low motivation, and it's not improved by sleep. But where is there overlap? Well, there is overlap all over the place with this. So, I mean, as a bit of a, we're going to explore fatigue in most, so we'll start with that. The problem is it's very vague. It's non-specific. It can be psychological and physiological. It's most commonly a combination of the above. It exists in 10% of our population, so our consultations. So 3 or 4 of the people, all the people I saw yesterday. It's there as a factor of chronic disease. About half of chronic disease is there in its most commonly reported symptom. But actually, there are patients that are more susceptible to it. It's more common in females, high BMI, low socioeconomic status, lower physical activity. So actually, as colleagues have been mentioning, we can't separate this biological from the psychosocial aspect of things. All of these things come together and is very, very challenging in a 10-minute consultation, which in reality is probably more like a 6-minute consultation, or even shorter once they've got into your room, you reviewed their notes whilst, trying to put this into the context of the patient's real life. So when you're investigating patients, where do you start? And we've got to consider that complexity that I mentioned before. If you've been to one of my blood test talks before, it is all about the history. The history is the is the place where we do the diagnosis, with examination and investigations helping add to that. But I will just impress on you that it is rarely a case where you've got, or at least it should be rarely a case, where after you've taken the history, you've got absolutely no idea what might be the cause of the problem. And the cause of the problem might in fact be there isn't a very clear cause to this problem. I'm not entirely sure what is driving this, and I can't be sure that. But I suspect it's more of a psychosocial issue rather than a medical one. So let's explore this with a few case studies, and I will try and introduce you to the broadest terms, the most common things here, as well as a few concepts with respect to this as a topic. So Annie, 26, I've been exhausted for 3 months. What are the key questions to help you narrow down the differential? So what are the questions that you would ask as your open questions there? First off, I'm going to give you one. What do you mean by tired? But what else? What else might we be exploring? What questions might we be asking to help us hone down and laser focus on a diagnosis of tired all the time? Period history? Yeah, that's quite, I suppose, quite specific, but yeah, I think that's pretty reasonable. I would always say like start with the more open questions when you're investigating this. Yeah, stress, yeah, sleep, lifestyle. These are pretty common. What else is happening in your life? I love that as a question because it gives the opportunity for patients to jump in there with what really matters to them. And often, if you give them, we talk about this golden minute or golden 2 minutes at the beginning, they can give you a lot of the information that you need. So, what's happened recently? Onset. Okay, is did you have an operation or a baby and bled a lot, and has things been checked since? Lifestyle, diet, yeah, I love that, and I think that's really, really important, often missed. And I think one of the things that's really lovely about the knowing that so many people in the room is that we'll all have our different kind of approaches, and people that are in the that have come up on the more medical model might be, often you'll find they're laser focused on like, is this thyroid, is this diabetes, is this anemia, whereas actually diet, lifestyle, what is it that you're doing? So diet, weight, physical exercise, sleep, a lifestyle, yet stress, recent events. How do you feel when you wake up after a long shift? What do you do? Social history, yeah. How much junk food, drink do they eat? Yeah, and absolutely. And I'm going on a bit of a journey around this kind of like what does what's UPF doing to my body? And actually thinking about nutrition and the quality of nutrition is something often that we don't explore. Yeah. Oh, yeah, I like that's a great question, Layla. What do they mean by tiredness in their tiredness in their terms? What did they do 3 months ago, and what's changed? Yeah, brilliant. So, I mean, essentially, this is quite difficult, but all of those questions I think are really, really good. What has changed? What impact is it having on you? When did it start? What triggered this off? And how is your sleep? And do you have any physical symptoms? All of these things can start to direct us towards, a diagnosis here. So let's ask Annie some more questions. I'm finding that if I basically feel really tired and sleepy. I'm finding it a chance to sit down, I start nodding off. My sleep has been terrible lately. I struggle to fall asleep, and even when I do, I wake up a couple of night times during the night. I often sleep through my alarm, and I feel exhausted for the rest of the day. She also reveals that she's a nurse in A&E. During my A&E shifts, I rely on caffeine just to keep going, usually a couple of Red Bulls and plenty of coffee. It's not that my mood's low. I actually feel quite motivated. Just my sleep is so poor that I'm constantly tired. So with Annie, perhaps, and you may not agree, please jump in if you don't, that we're starting to point ourselves at a diagnosis potentially of tired sleepiness rather than fatigue. So let's start off with sleepiness. And I start here because the rest of it's going to be more sort of fatigue based. And particularly because I never learned anything about sleep during my 10 years of medical school slash GP training. But we're asked about it at all, and it's just so important. And patients don't really think it's important, but insomnia is important. So what do we mean by sleepiness in this context? Well, bad sleep. Yeah, yeah, well, absolutely. Yes, you've got some coffee. I'm not sure about cortisol resistant, but it does tend to suppress hormones that help you with your sleep wake homeostasis. It may well be suppressing, making you cortisol resistant too. But bad sleep is really, really common. It's at a symptom level in patients with chronic or the patients that present in primary care. It's around about 30%. So actually, 3 out of 10 people are have bad sleep, but they don't even tell you because they think it's just their lot. The syndrome of insomnia in around about 6 to 15% of them, okay, with an expected cost of £34 billion a year to lost productivity, lost days, and in the region of sort of 400,000 days of lost productivity during a year. So what drives sleep? Well, just in brief, we've got these two cycles of sleep wake homeostasis, i.e., the longer you're awake, the more you feel sleepy. So this is adenosine that is commonly associated with this. So it builds you going as you're awake, and when you sleep, it drops off. And at the lowest level, first thing in the morning, when you're out of bed, and then it starts to build again. Fairly important. And what impacts this? Well, caffeine. Yeah, no worries. Please come back as you need to. Yeah, what impacts this? Well, actually, caffeine massively impacts this. So caffeine suppresses your speed of adenosine production as well. So actually, if you're having a lot of caffeine, you might find that when it's time for you to go to sleep, you might find that it's you might find you're unable to get to sleep. So that's the first bit. And the second thing is circadian rhythms, and these are really driven by light. So light Low light increases, sleepiness later in the day, and bright light suppresses that first thing in the morning. That's where your cortisol comes in. So this is driven no matter how long you've been awake by your 24-hour clock, so the suprachiasmatic nucleus, which is independent of that other system that I talked about. Cortisol in the morning, sleep in melatonin in the evening, and this kind of goes no matter what happens. And this is what really causes you a problem when you're doing night shifts and when you are doing long haul travel. And if this gets out of sync, well, then you struggle. That's why you're awake at 3 o'clock in the morning and exhausted at 2 o'clock in the afternoon, because these two things come out of sync. Because this is, how long have you been awake? Been awake for 23 hours. This is going to be sky high, but does it link up with this kind of daily changes? So what about insomnia? Well, we talk about acute insomnia, so sleepiness, which is less than 4 weeks of symptoms, or chronic insomnia, which is greater than 4 weeks of symptoms. Fairly straightforward. And the other thing I'm going to share with you here is this model of insomnia, because it's quite difficult to get your head around, because often we'll go looking for this kind of the physiological cause of people's sleep. So I really like this model here. So this pre-morbid state of risk of insomnia, and some people are just very, very prone to it. I'm not, mine's very, very low. But essentially you have precipitating factors. So that might be an injury, an illness, a new baby, something like this, or international travel, and you pass this insomnia threshold, so you have insomnia, which is basically poor initiation of sleep, waking up overnight, feeling unrefreshed with impact during your day. Menopause, absolutely, yes. Yeah, that's certainly contribute to it. But then over time, you end up developing perpetuating factors. And perpetuating factors might be caffeine, alcohol, drugs, or unhealthy habits of looking at your phone in the middle of the night, and of course that wakes your brain up as well. And so over time, when the precipitating factor is settled down, hormone levels have dropped, or so have sort of normalized at least, or your child is now sleeping a little bit better, the perpetuating factors are what keeps you in this insomnia phase. So it's just important to think about that, and think about what people might be doing to keep them in this level of poor sleep. What are contributing factors to the quality of sleep? Well, loads of things. If we had more time, we'd explore on this. Exactly, screen time. You're completely right, Asma. So stress, light, routine and work, stimulants, sedatives, respiratory function, nocturia. Don't forget about that. If you're getting up 8 times a night to go for a wee, whether it's prostate related or just habitually related, is really important. Restless legs, sleep apnea, chronic illness, nocturia, again, kids, depression, anxiety, all kinds of things that are going to be impacting on you. And you might think, well, why bother asking people about this? Well, actually, it leads to impaired daytime functioning, impact on mood, tired throughout the day, low energy and poor concentration, and ultimately health problems. If you do not sleep enough, if you have if you have poor sleep, the risk to your health is greater. 30% more obesity if you get fewer than 7 hours of sleep. It was higher risk of higher injury risk with night shifts, and increased all-cause mortality of up to 13%. With huge costs to the UK. So a very, very big impact, and we should really be asking about it. Now, briefly, what can we do about it? Well, if people haven't heard of sleep hygiene, I've got lots of talks on sleep if you want to listen to it, about sort of improving your sleep and about the real impact on sleep hygiene. But it's about helping people understand about their environment, their bedroom environment. Is it a comfy bed? Is it dark? Have they got a good sleep schedule? Colleagues have mentioned there about screen time, or do you stop before you go to bed? Do you have that space to kind of wind down? Nightly routine, importantly thinking about the impact of light on those circadian rhythms, as I mentioned before, and then healthy habits too. So this is about actually not steeping yourself in caffeine to stay awake, about not having lots of like sugary things, or caffeine drinks as well. Do blue light a big question? Not entirely sure is the answer. I'm a little dubious. Maybe they do. That's certainly something I'd like to explore in the future. So This is evidently a talk about blood tests as well. So I'm sorry I can't give you a very clear answer on that, Richard. Maybe is the answer. Low light does. Yeah, yeah, no worries. So blood tests, we're talking about these. So what blood tests are we talking about? So we've talked about sleep. I'm going to put sleepiness to one side for the moment. We're talking about blood tests now. So which blood tests are, if you had only had 5, what blood tests would you request for tired all the time? After we've taken an amazing history, after we've asked them about sleepiness and fatigue. Thyroid, yeah, okay. I'm going to give you a tick for that one. Yep. Very common cause. FBC and ferritin, yeah, you can have those two together. Yeah, brilliant. Okay, we got two out of the ones on my kind of general rhythmic list. Folic acid and folate, yeah, potentially. I don't always request those. I really ask. HbA1c, absolutely. A lot of diabetes about. I think folic acid and B12 is pretty reasonable. Testosterone, not so frequently. A lot of patients will ask for it, but I don't generally investigate testosterone. Although I must say that may be challenged as we go through. Vitamin D is an interesting one. Yeah, I don't generally request cortisol either. We will come on to a couple of these things. Liver function, yep, absolutely. It is a general indicator of health. TTG, yeah, that's a good suggestion too. Not usually my top 5. It's in reality I do ask for it quite frequently. The other one I tend to do is UNE. The reason being that we've got some common causes of fatigue, in all of you mentioned there as well. But actually, especially when the patient first presents and with the association with chronic disease, this is often an opportunity to look at the health overall in general. And actually thinking about the 2 big filters of the body is really important and very, very common ones as well. But you're all right with, absolutely correct with all the other ones as well. So talking about sort of ferritin, looking for iron stores, B12 and folate, very common, around about 10% of older adults. Bone and vitamin D, very common. Should we request it or not? I'm going to answer that question as we go through. TTG, and for those people that don't know, that's a celiac disease test, very commonly a missed cause of fatigue. Glandular fever, rheumatoid factor CCP, maybe. Testosterone, maybe. Patients really want to do it, but there are lots and lots more blood tests to be done there, and this is why it's so difficult, and this is why we need to be using sort of like acting within our zones of competence and not being too scattergun about this. So this is a test about the ones on the left, yes, almost always. The ones on the right, think about what we're actually looking into. So Annie, just coming back to our case here. So we thought actually, this fatigues, tiredness, sleepiness, okay. But we've asked her some more questions. We actually dug a little bit further. And, we've asked her about whether she's got any other physical symptoms. She goes, well, now that you mention it, I've lost about 5 kilos over the last 2 months and I've been sweating like crazy at night. My question to you guys is, how does this change things? And is there any examinations you might want to do? Yeah, thyroid, yeah, pretty reasonable question. Yeah, hyperthyroidism could certainly cause this. Anything else here about this? Thinking about the patient as a whole. Thyroid's a very reasonable thought. Yeah, yeah, absolutely. Are we dealing with something much more serious? Yeah, abdominal exam, potentially a fit test. I mean, considering the age there, I think I'd probably want to be thinking about, what the indication is. I don't think I'd be doing that until I'd got an FBC back. Yeah, but absolutely, yes. So Gazala and Emily picked out there. Yeah, and Hannah. Yeah, definitely red flags here. So we've got this thing. It's about weight loss, night sweats, 26-year-old with this rapid onset. We've got to be thinking about what else is going on here. So these are common ones, when I was thinking about this. So significant weight loss, fever, night sweats, lymphadenopathy, so feeling the neck, feeling the abdomen, looking for hepatosplenomegaly, so enlarged liver, enlarged spleen. Focal neurological symptoms, including visual changes, unexplained shortness of breath, and disease-specific red flags, which is why we've got to be thinking about putting them in the context of the age of the patient and about what we're looking at. So in this case, just as a start of a 10, white cells and platelets here. So raised white cells can come up in infection, but actually in this case here, we want to be thinking about leukemia, lymphoma. Think about what else is coming here. We've got a whole host of symptoms here. Muscular weakness, bone or joint pain and tenderness. And thinking about, so I had a case where the patient was just, they just stopped walking and like, I don't know why his bones hurt so much. And this was a case that came up as leukemia. So easy bruising, easy so petechiae and purpura, swelling of the lymph nodes. And again, we put here in platelets too. So if you've got low platelets, we might indicate towards bleeding. And of course, these things are very, very serious and need to be dealt with very, very soon. So in this 26-year-old, if she did have intense night sweats and weight loss, I think I'd be wanting to blood test her very rapidly for this as well. B symptom examination. Yeah, you're exactly right. Yeah, and loss of appetite. So a couple of other cases here. So Amira, 28, she's got a 4-month history of gradually worsening fatigue, dragging herself through work, doesn't have the energy to do anything when home, feels breathless running for the bus. And this is a HB 9775. So most likely diagnosis. Anybody want to guess most likely diagnosis? Idea, yeah, probably iron deficiency, secondary to heavy periods. Yes, absolutely. Most likely here. How about Kevin? So exactly the same history. He's a 65-year-old fellow, 97 MCV 75. Iron deficiency anemia, but what is our concern here? How does this change things? Yes, fit test would be useful, but I mean, I suppose what I'm thinking here is, yeah, have we got GI list? He's got no menstrual losses. He's got no very good reason to be losing blood. And similarly, if Amira didn't have any very good reason to be losing blood, we need to be thinking about it as well. But of course, so menstruation is a really common cause of anemia, whereas in a 65-year-old fellow, we've got to be thinking about like where is he losing this blood from, and yeah, and the risk of GI malignancy here. So I'm going to just move through this very quickly, because if you'd like to come and find out more about iron and FBCs, I do an entire talk about that. So please book on for another one. If you did enjoy that, please come along. Maybe you've been to it already. But essentially, we're talking about anemia here, and we need to be considering particularly about the information around it. So what's the age, the onset? How long has this been going on for? Is it changing over time, and what sort of causes might we be looking at as well here? So and thinking about size cells here. So we've got microcytic, which is what's the case in this one, which is often iron deficiency. It can be hereditary as well, but pallor, heavy menses, shortness of breath and exertion. So we need to be thinking about that. Normocytic, which is common in chronic disease, but also can be in early blood loss too, and then macrocytic, which we'll come on to as well. But again, this is a thing you can explore. Please come along to the FBC one if that would be helpful to you. But importantly, and the thing I want to pick out here is that in iron deficient anemia in older patients with no clear cause is a red flag and needs to be investigated, and particularly if it's worsening. So 72-year-old John feels increasingly lethargic and lightheaded when standing up and listless. He's got 6 months of symptoms and he's on ramipril and indapamide, and he's got no red flags that we can pick out as well. So what is the key test here? Each of these things is to kind of highlight one thing. What would you be most, you had one test, what would you request? Yeah, blood pressure, pretty reasonable. We're doing one blood test. ECG, again, very, very reasonable. PSA, no, not. I wouldn't say so helpful. I I mean, PSA is probably a good part of overall here. I've given you information. Sometimes there's a question of, can you guess what I'm thinking about? Hemoglobin, yeah, brilliant, yeah, brilliant, Sandra, yeah. UNE, I think is helpful here. So the clues here are the lightheadedness when standing up and sort of listlessness, and the ramipril and indapamide, both of which cause hyponatremia. So we're talking about UNEs here, and again, these cases are to help kind of explore a problem. And when we send this off, we bring it back and we can see that he's got a a sodium of 123, where it was 135 when it was done a year ago, normal potassium, creatinine, urea, and CKD3A, most likely. So it's about the same as before. But the real change here is that his sodium's gone down. So just remembering that actually this can be helpful to know about the patient's sort of general health, but that hyponatremia can knock you on your back. And thinking about these causes with urea, electrolyte, we've got chronic kidney disease, which can make people feel tired over long period of times, but actually that hypo and hyponatremia can make people feel unwell. Hypo and hyperkalemia can make people feel unwell and be quite deadly. If you'd like to find out more about this particular topic, please join me for my UNE topic on this blood series as well, which we did last week and going to be doing again early part of next year. Dehydration also pretty common as well. So thinking about UNE and thinking about how that fits in to the overall picture of tired all the time. So Ravi, 45, so he feels sluggish after meals for the last 1 year, recently gained some weight and become more sedentary. He drinks about 2 pints most nights. What tests are we going to do to help us investigate this, apart from all the basic ones, which is the key one you might want to do? HbA1c, that is a very reasonable, it's not the one I'm thinking of, but agree, LFTs, yeah, absolutely. So he does some LFTs and these are the results. So we've got a mild rise in ALT and AST, okay? And my question to you all here is, yeah, agree, definitely check diabetes. Yeah, I forgot that off this one. But yeah, definitely check diabetes. So does this show a cause for his fatigue? And would we be thinking about repeating this, a liver screen, or is this around sort of lifestyle here as well? So I'll answer some of these questions for you. So one, certainly repeat is important. Yeah, poor metabolic health, completely agree. Yeah, so we've got a fellow here that is you know that the LFT is often what will come through as, oh, such and such got slightly raised LFTs. Let's have a conversation with them about lifestyle, etc. But actually, is this a sign of something that is, you know, the broader picture as you correctly identified? It does need a repeat, most likely. Is this going up? Are we catching this on the way up? Is this stable? Is this a thing that we can improve on if we have a good conversation with him about it? Does he need a liver screen? Well, potentially, you know, there are lots of causes for this. We need to be thinking, are there risk factors for hepatitis? There are risk factors for, you know, family history of autoimmune problems as well. But you know, you speak to Ravi and says, oh, so this must be the cause of my tiredness. So what is the likely diagnosis here? Well, I love the way you put that, Anita. So we're going to keep with that. So yeah, poor metabolic health. Is this likely MASLD? So this is the new name for NAFLD, okay, non-alcoholic fatty liver disease. So this is metabolic associated steatotic liver disease, which really fits in with your thing there about metabolic health. So it could be related to it, you know, like this can impact on it. It's part of the overall picture, you know, of metabolic health. We might look at something like a FIB4, which gives us an indication of liver scarring. So that's a test that you can request on ICE as well. We might need to think about liver screen, but there are many other tests here, as you've mentioned. So HbA1c, UE, full blood count. We might be need to look a little bit more broadly of him. But we also need to consider stages of liver damage. And certainly as one's liver works less well, this is going to be a major cause of fatigue. But it tends to be that, you know, fatty liver is what we're talking about. It tends to be late on towards cirrhosis that people really start to notice. So what I would say here, as correctly identified by some of you, take this as an opportunity to help understand, you know, that it's really difficult to pinpoint a cause, but this is your point for intervention for lifestyle, deconditioning, mental health, stress, metabolic health, an overall assessment of where they are. This is really prevention. Now, you know, does the funding, does the capacity in primary care really follow being able to being able to have a really good conversation about this? Well, not always, but actually this is where this wonderful, you know, multidisciplinary team that have joined us today can be really helpful. You know, is this actually a conversation about fatty liver disease or blood tests, or is this actually a conversation about metabolic health and exercise and lifestyle and mental health and stress and all of these other things that may be driving the having a couple of pints to unwind of an evening? So just some thoughts, food for thought there. So Danny, 48, feels slowed down, tired, gained some weight, skin dry, and mood has dipped. 6 months. And she says, Mum had something very similar to this. What is your suspicion and what is key test? Well, in the interest of expedient, actually, if people are fastest fingers, brilliant, gold star. You were quick. So we're thinking about TFTs here, and these are some of sort of the classic, brilliant, love it. Yeah, we'll come on to that as well. I was wondering whether somebody might mention that. So TFTs here can be quite helpful. So this is looking for thyroid disease, particularly hypothyroidism. But I was going to ask people whether there might be another cause for this as well, which you've jumped in there, Richard. And actually, perimenopause can definitely be driving this. And the point I would make here is that a lot of times people aren't asked. Now, fortunately, with a change in our understanding in this and some really good sort of I'd say public health campaigns, but driven by Davina McCall particularly, people are much more aware of this. And if your thyroid comes back and is normal, we might need to be thinking about the surrounding times of life. Is this a perimenopause issue? Somebody mentioned about testosterone before. Is this a low testosterone issue? We might maybe think a little bit more broadly, but we've got to also give mind to the fact is that gained weight, dry skin, dipped moods, feeling slowed down, constipation, and similar, all classic features of hypothyroidism. Hypo being low thyroid. And this is a thing that I think a lot of people know about, but what do we actually know about thyroid? So thyroid is a gland sitting in the front of your neck, okay? It's also got the parathyroid glands embedded in it, and they're the ones that tend to link with vitamin D and calcium metabolism as well. But I describe thyroid gland as the accelerator of the body to patients, okay? It's when there's lots of thyroid hormone about, the body goes quickly, okay, so things move faster, including bowel, including heart rate, including metabolism. So you lose weight, so your heart rate goes up, so you get diarrhea. And when you take the foot off the accelerator pedal, you result in the exact opposite of that. A little bit of a diagram to help understand how it functions. So essentially, the hypothalamus tells the pituitary, which is another gland in your body, so in the sort of base of your brain, basically, to produce thyroid releasing hormone or thyroid stimulating hormone. Thyroid stimulating hormone drifts down to the thyroid gland, which then produces thyroxine, which is your accelerator pedal. Now, it's got this thing called a negative feedback loop, of which they're all throughout the body, but I thought this would be a good opportunity for those people that might be less au fait with this as a concept, to know that as your thyroid hormone goes up, it sends signals to the pituitary to say, hey, we've got enough thyroid now, you can reduce the amount of TSH. If TSH goes down, which reduces the amount of thyroid hormone being produced, and when the amount of thyroid hormone being produced is not quite enough, it sends a message back to the pituitary gland to produce more thyroid hormone. This is what we call a negative feedback loop. And in understanding that, we can start to interpret in thyroid blood tests. So if you've got a normal TSH and a normal T4, we are euthyroid, so normal level of thyroid. Also, if they're being treated appropriately with the right medications. So this is what we're aiming for. If you've got a high TSH, okay, and a low T4, you've got hypothyroidism, okay? So hypothyroidism because you've got low T4, but your thyroid gland, sorry, your pituitary gland here is throwing out saying like, hey, produce more hypothyroidism. Hey, sorry, produce more thyroid hormone. Hey, produce more thyroid hormone. And the thyroid gland's going, I can't. And as a result, this loop goes round and round and round. So you notice the TSH goes up and up and up, but your T4 stays low. Now, how about I'll pop it in here. If the T4 is normal or high, but the TSH is still high, well, essentially that is usually when the patient has forgotten to take their thyroid hormone and has taken it just before they've had their blood test, because it's a reflection of the last kind of six weeks of treatment. So you'll often notice that. So it'll be sort of spurious, and you say, are you taking it every day? And they go, no. And that's often what you'll see. And then for hyperthyroidism, you'll have a low TSH and a high T4. So the thyroid's chucking out loads of thyroid hormone, and it's telling the pituitary, don't produce any thyroid, don't produce any thyroid, sorry, TSH, and then that's going back to the thyroid gland. Okay, hopefully that's helpful and hopefully help you interpret it and understand it. But this is a really common one that we'll do, and a really common cause of tiredness and weight gain and similar. So what are the thyroid symptoms? What is hypothyroidism versus hyperthyroidism? Well, more or less they are, they are the yin and yang, the opposite. As I mentioned, this accelerator pedal kind of an analogy. So cold intolerance, hypothyroidism; heat intolerance, hyperthyroidism; weight gain, hypothyroidism; weight loss, hyperthyroidism. Depression and irritability, hypo; nervousness and anxiety, hyper. But with this kind of fatigue, insomnia, and hair loss sitting in the middle. So a patient might just come in and say, I feel exhausted. And you think that actually, the accelerated pedal should be perking them up, but really isn't. So I find this quite helpful to think of that, and then you can help to kind of explain it to a patient. Any questions on any of the things we talked about before up to this point, please pop them in the chat, but hopefully that's a useful way of looking at it. So case number 7. So we got James, 51, 8 months of worsening fatigue, thirst, weight gain, weeing a lot, BMI of 31. What else do we want to know, and what test will be most helpful? If you can be quick, pop it in the chat. HbA1c, excellent, very good. And we find his is 56, which is a diagnosis of type 2 diabetes mellitus. And again, we're going to go through this very rapidly, just on the basis that we could days and days. It is being recorded. Yes, they're also happy to share the slides, but please don't share them with anybody outside of this call. So diabetes. So this is a chronic metabolic disorder with insulin resistance, impaired insulin secretion, hyperglycemia as well. They often end up with fatigue due to poor glucose utilization, and it's associated with this metabolic syndrome, as we've mentioned a few times as well. Obesity, inactivity, family history as well, and it can be asymptomatic, but it can be associated with tiredness, thirst, polyuria, blurred vision. So I would consider that a core part of the history. Think overall, when you're seeing patients with this, think about family history, think about metabolic dysfunction, as Anita mentioned earlier as well, thinking about early intervention, because in reality, even when we're having conversations about this, I'll come on to that in a second. So it's about kind of intervening early, because this is what we want to prevent. We want to prevent the fatty liver disease, heart damage, eye disease, neuropathy, and nephropathy from getting worse. Now, is it a reversible metabolic disorder? To a degree, yes. Yeah, to a degree, yes. You'll have patients that are so you'll have patients that that will be able to improve their HbA1c, improve their HbA1c to the point where their blood glucose control is within range. And in fact, there is some evidence that if intervened early enough and aggressively enough, you can reverse that insulin insensitivity. However, when it's kind of taken hold, and for some people that are just genetically unfortunate, they are going to have this insulin sensitivity, no matter whether they reach a normal body weight, if they exercise, etc. It'll all help, but you may not get all the way there. So, but I think it's important. Yeah, absolutely. I think there are lots of things around it. I think I'll I think it's just really challenging. But the thing is, what I'd like people to take away today is that there are often opportunities to intervene here from a kind of a gross point of view, like an overall patient point of view, where we can make a big difference to prevent this longer impact here. And it's not just about the tiredness at that point. So like regard to bloods, do you always recommend doing for sleep hygiene first? I feel do a lot of TATT bloods. I think it depends, Emily. So I think whether you do blood tests for everybody is a little bit of dependent on the history. If it's very clearly I need more sleep problem, then I would go down that route. I think in reality we are going to be doing quite a lot of time bloods, but my advice would be to think about what you're looking for. Think about the symptoms that they're presenting with. Think about the overall picture, and then request fairly specifically. I think that base 5 that I suggested are where I would start, but just be a bit careful about blanket requesting, as we will come on to in a case shortly. So Emily, 29, so she works in A&E, feels tired and tingly in her fingers, aches all over, recently lost some weight intentionally, has radically changed her diet to be more health conscious. What are the questions and what are the key investigations? Actually kind of links into what you were talking about there, Emily. Hematinics, reasonable thought. B12 deficiency. What makes you think it's B12 deficiency? Yeah, so well, yeah, so we ask more questions. Yeah, tingling, absolutely, and a change of diet. Yeah, great. Very good questions as well. Probably new diet changes. Yeah, if I told you she's decided that being vegan is the healthiest thing to do, and so she's changed her diet enormously, and so she's having a purely plant-based, natural plant-based diet. Now, the challenge here, of course, there's lots and lots of health benefits to plant-based diets, but some challenges in the fact that one can't get vitamin B12 without fortified foods or supplementation in vegan diet. Unfortunately, our bodies can't make it. But in this case, you're absolutely right. The tingling there is a sign of vitamin B12 deficiency. Again, slightly hammed up here as well. And when we do her blood tests, we can see her B12 is low. Okay, so it's low here, and that is likely what our concern is here. Now, somebody mentioned hematinics, and I think FBC is really important too. What are we looking for on that blood test? We want to check the folate too, important because they often come together. Brilliant, yeah, MCV. Vitamin D's come along with this as well, so we've got a combined deficiency. Calcium normal, phosphate normal, ALP normal as well. But those they come with the bone test too. And I recommend that if you're going to request a vitamin D, make sure that you request a bone test too, because if you're going to replace it, we need to know what that is. So what B12 and folate deficiencies? It's really common. Greater than 10% in over 75s, 5% in over 65s. It's involved in DNA and myelin synthesis, so this kind of links together in our macrocytic anemias, or our raised MCVs. It comes in meat, dairy, and eggs, so unfortunately all animal products, but there are lots of vegan foods that are fortified with it, or people can take supplements too. Folate is in green leafy veg, and again, you might notice this in people with very restrictive diets, particularly people with the kind of typical beige diet as well, or people that drink lots of alcohol. It's very common in people with alcohol excess. There tends to be a gradual onset, so it doesn't tend to be all of a sudden. Be worried if it's more sudden. You might see signs of anemia. You also might see memory issues, which is often why with patients with alcohol excess, then we will often supplement them with B12 and multivitamins as well. So risks: vegan diet, pernicious anemia. So we check for intrinsic factor for that. Gastric surgery, metformin and PPI long term can also reduce absorption of these nutrients too. So make sure that you investigate folate as well, and do not treat one without the other. So if you treat folate without treating vitamin B12, you might mask that deficiency, and then you can get a rare but serious neurological change very quickly as well. So these are things to be thinking about. So my question is, so the question was asked earlier, should we be treating people with low vitamin D? Sorry, testing people for low vitamin D. Well, it's a bit tricky, actually. You might argue yes, you might argue no. Sometimes I'd say yes, because for people where you're a little unsure, you don't necessarily think there's a medical cause here, you might find that it's quite helpful to be say, well, I checked it, your vitamin D's low, and this can help explain why you're feeling so tired. But it's so prevalent. 1 in 6 adults, okay? Very common in kids too. In 11 to 18-year-olds, it's 40% in the winter. So should we be testing for it when everybody's going to be deficient? When actually, in reality, people can take an over-the-counter supplement, particularly if they're at risk, to help top that up as well. Vitamin D we use in bones, calcium, metabolism, and for muscle strength as well. It comes from sunlight and UV exposure, of which we just don't get an awful lot in the UK. It's more common in people with darker skin, and if they get less kind of skin exposure to the sun as well. And we can do loading doses, but ideally stopping people getting vitamin D deficiency in the first place is a really good idea. So helping people understand a little bit about healthy sun exposure is really important. And for those that are at risk, and particularly because in the UK we just don't get enough sunlight, a daily supplement over the counter. Yeah, I'm completely right. Yeah, especially if people come from sunny countries, massive change for them. But we might not necessarily need to check them for it. We expect that they are going to be low in vitamin D. So, I would be comfortable recommending a supplement, particularly over the winter, and guiding them with that. But yeah, it's reasonable to do vitamin D. I don't in everybody, but I do recommend people take vitamin D supplements very quickly. It's a very low risk intervention, and very inexpensive as well, and may save us, a bit of a bit of money, I suppose, in the long run. Because if we're going to do a test that we know is going to be positive, why not just treat it? So, Dennis, 48, brought my wife, tired all the time, 2 years, worse the last 2 months, always wakes feeling unrefreshed but sleeps through the night, wakes with a headache and sore throat, drinks 4 coffees in the morning to get himself up, and he finds himself drifting off during the day. Any other questions or investigations for Dennis? EBV? Yeah, reasonable thought. Sleep apnea. Very good. Yep, Denise, well done. And particularly like this is quite common. So sleep apnea is very, very, very common for in our society, as we're going to find out. So this gentleman's got a raised BMI, a neck size of 17 inches. So BMI is quite tricky, but actually, if you've got a neck size of greater than 17 inches for a man or greater than 16 inches for a woman, actually the increase of sleep apnea goes up. And his wife says he snores like a rhino. And what would you do next? What would you do next for this fellow? And would it make a difference if I told you he works as a lorry driver? So this is really important because sleep apnea is so prevalent, and it might surprise you. Yeah, absolutely. Sleep study and DVLA advice, very, very good. And the DVLA advice is what I really want to hammer home here as well. So it's so common. 4% of men, 2% of women for obstructive sleep apnea syndrome. Okay, this is the excessive sleepiness during the day. And importantly, it may be in as many as 15% of lorry drivers, causing in excess of 400 deaths a year from expected, falling asleep at the wheel for lorry drivers. Only 1% of people are diagnosed with obstructive sleep apnea syndrome, and a lot of people can't tolerate it. Now, it's important because people have to stop driving if you have excessive sleepiness and you expect sleep apnea, and inform the DVLA. And this is very difficult, and patients may not want to talk to you about it. Although interestingly, have people been finding that they've been asked about sleep apnea a lot more recently? And if anybody's got any thoughts as to why that might be, please pop it in the chat. Risk factors: obesity, alcohol, smoking, large neck circumference, really, really important as well. And asking people to do the Epworth Sleepiness Scale, ESS, can be helpful in finding out about insomnia. Again, I've got talks on obstructive sleep apnea. Should you want to learn about that, please let us know. So why are we being asked about, I think I might have obstructive sleep apnea more recently. So pop it in the chat and we'll come to it if anybody answers. So case number 10, Aisha, 52, generally tired. Yes, absolutely right. Manjaro. Yeah. Yeah. Generally tired, achy all over, no stiffness, unrefreshing sleep, stressful job in marketing, no family history, seen a colleague already, test done, all of these things, all normal. What are you going to do next? Giving you all the history. She's got another history to this. No family history. What next? Menopause chat. Yeah, great answer. I might have to change the patient, because that's a very great answer. Yeah. Okay, this one's not about menopause. So what else might we do? Oh no, I'm fine. Yeah, no menopause symptoms. I'm already on HRT. We'll call that. Yeah, already on HRT. Very good point, and I'm so glad everybody's so attuned to menopause. One of my interests actually is better menopause care. Any cancer markers? No. Psychiatry history? Oh, just stressed. Anybody want to do any further blood investigations? Fibromyalgia. Brilliant. Nobody's fallen into my trap. Excellent. Well done. Actually, yes, this is most likely a presentation of fibromyalgia, but I absolutely accept the menopause suggestions there as well. But what has happened next is they've received an ESR, CRP, ANA, rheumatoid factor, glandular fever, and immunoglobulin, and she has got rheumatoid factor positive. How do you explain this to Aisha? And at what point will you do a referral? What are we going to tell her? To this question, our diagnosis of fibromyalgia. Perhaps a bit of a big question there as well. I think the point I'm making here is, I'll spot if anybody writes in the chat here, is that actually in this case she doesn't have any joint swelling. She has just sort of general aches and pains and no stiffness. And the likelihood is she does not have rheumatoid arthritis. So the point here is rheumatoid factor does not necessarily equal rheumatoid arthritis. Okay, a rheumatoid factor is present in 70 to 80% of rheumatoid arthritis, but in 5 to 10% of healthy adults. Also infection, aging, smoking. CCP can be more specific. Now, why have I put rhubarb here? Well, actually, this case is a note to just think about what you're looking for. You all did amazingly well there. You all thought more holistically. You all thought about, is this fibromyalgia? Should we be doing a triple S, plus a widespread pain index to look for fibromyalgia? But actually, if you order enough serum rhubarbs, okay, this is kind of the slang in the biz, enough serum rhubarbs, something will come back positive. And that puts you into a very challenging corner as well. So be careful with your tests, be specific with your investigations, and then test with purpose. And not necessarily curiosity. Oh, I'll just check this. And this comes out very frequently. So we all identified she probably had fibromyalgia, but people always seem to get CRP, ESR, ANA, which is also positive in around about 15% of normal healthy adults. But when you've got a positive rheumatoid factor, a positive ANA, it is very difficult to justify not referring them to rheumatology. And when we clearly could see this is more likely fibromyalgia. So final case here. Gosh, there's a lot to cover in this. There's even a little bit more after this, but we'll finish at this point. So we've got Mohammed, 87. Slowing down and tired over the last month. He doesn't leave his bed often and fights to stay in bed if people try and get him out to do anything else. His appetite's poor. It's probably going on longer over the last 1 to 2 years. He lost about a kilo, 2 kilos over the last 1 to 2 years as well. PM8, past medical history, COPD, hypertension, and mild dementia. Ramipril, amlodipine, simvastatin, 3 inhalers, cocodamol, and donepezil. And as all his recent tests are normal and stable. And his family say, so what next? Can he have a scan? What's going on here? He's getting worse. So any thoughts on this, and any thoughts on what Mohammed is going to say, what his take on this is? What might be going on? Because Mohammed says, can you just leave me alone, please? What are thoughts and where next? Well, in the interest that we're in our final 2 minutes of this presentation, this is just a mind here to think again broadly. Think about complexity in the older patient. So fatigue is such a common symptom, and it's a common symptom of frailty, social isolation, mood, progression of dementia, immobility, polypharmacy. He's on 8 medications, of which how much they're actually helping, sarcopenia, multimorbidity. We've got to be, just be a little bit careful here, and actually, thinking about less testing, more listening. What is actually going on in his life? What is the whole context here, and how and how does this link in here? Does he want more tests? What is his intentions? What is his wishes? Does he just want to be left alone? Is this depression, or is this just actually, I'm 87 years old, I've got lots of medical problems, and I just sort of feel like I'm winding down. This does happen. It does happen in these later stages of frailty. It's all about optimization, and as a big driver for something called CGA. And again, if you want to learn more about that, more than happy to do some teaching. Please put it in the please put it in your feedback. I'd love to teach you about CGA. It's so important. But again, poor diet, yeah, nutrition. What is going on here as well? So diagnosis can be inherently complex, and a blood test does not necessarily give you the answer. Utilize the team, think broadly, don't necessarily think about the next test, and as you're correctly kind of identified there, think about the patient's patient in front of you as well. So finally, TAT in review. TAT, tidal time, is formed from a combination of factors. Think lifestyle, medical, and psychosocial as well. Good clinical reasoning and history is paramount. So be specific with what you're looking at. Avoid blanket tests. Okay, so think about what I'm actually looking at, and apart from this sort of core 5, think about what you're aiming yourself at as well. And just finally, remember, sometimes it doesn't need a test, rather a chat.